Okay, so yeah, hello everyone. I am Lewis Ralph. I'm a health economics partner at Roche UK, and Oliver and I have been working on this geospatial care close to home modelling. So yeah, we're going to talk to you about that. Which one am I on? There we go. Yeah, so in terms of the rationale and the reasons for this, so as I said, I'm a health economist. My usual work is NICE submissions, so we do kind of national reimbursement. We work with our global teams, Carolina this morning, to develop economic models, and then they will be submitted to NICE for kind of national yes or no decisions. And then my interest then goes, and things that I've not done previously, is what happens after that. So obviously, and yes from NICE is great, but we've got to get that treatment out and available to patients kind of across the country. And we used MS as a case study. So obviously Roche has got an MS portfolio, MS medicine, that's out there being used by patients. And we recently had a subcut formulation. So in theory, we could expand the uptake and the access of that medicine away from some of the specialist IV centres. So we looked at mapping out kind of what that would look like in terms of outcomes across the country. So objectives is to basically look at the NHS infrastructure, so which treatment centres could give the medicine and the potential treatment centres that weren't doing previously, and therefore kind of map out the geographical access for patients across England. Then obviously you have two different scenarios, one without treatment, the new treatment centres and the current state of play, and then one with the new ones added in. So estimating how that improved access would influence kind of outcomes for patients, for the healthcare system, and for kind of healthcare outcomes as well. And identify which of the new options would be the best to make the most impact for patients, the healthcare system, kind of clinical outcomes. The rationale is that, or the theory behind it is that patients that live further away from a treatment centre are less likely to choose that treatment and less likely to stick on that treatment when they do choose it. So if you've got to travel for your medicine for over a longer period of time, you're more likely to choose something else that's more convenient to you, which meant that, or you could hypothesise that they're missing out on higher efficacy medicines for more convenient options and therefore getting worse long-term outcomes. There's a range of kind of sources here on the evidence for this, but as I said, we went with an MS pilot model. And why this matters, kind of mentioned it there, but unequal access to treatment leads to health inequalities across the country. So patients in more rural areas are less likely to get better treatments. Imperfect access to medicine leads to imperfect outcomes or poorer outcomes across the country, and potentially higher costs for patients in terms of out-of-pocket costs, and higher costs for healthcare services in terms of worse outcomes longer term. Improving access to better medicines means that they're likely to get better outcomes, leading to better results for payers and patients. Obviously, there's a lot of evidence that we've got to populate that model with. So the challenge is how do we quantify where those gaps in access exist, and then how do we rank the sites and prioritise which ones are the most appropriate based on a particular method that we're going with. And we need something that's reproducible, because this was a pilot model and we'd like it to be available across kind of a portfolio-wide, improving care close to home for the NHS generally, not just specifically in one disease area. And this is what Oliver's going to talk around in a minute, but the proposed approach is obviously to gather the data sources, looking at kind of ONS, census data nationally, feed all that through R and R-HTA, and in theory use the tool to guide service development decisions, patient treatment choice decisions, to better give better patient options and treatment options for across the country than what was previously done.
All right. So I'm going to walk through kind of general technique that we have tried to implement here. A few different challenges that we kind of needed to address in this framework. So first, we needed to determine where sites are located and where patients are located. Then we need to determine which sites those patients are actually using, how long it takes them to get there, and what the impact of that travel time or travel distance is on certain outcomes. And then the final step is to take a set of candidate sites where maybe treatment could actually be provided in the future, and figure out a way of systematically determining which of those options is actually the best location to provide treatment in the future. So I'll walk you through how we approach all of those different problems. So I'll start with where current sites and patients are located. So for site locations, we just use data available from the NHS about where trusts are located, and we assumed that some of these sites were existing sites where treatments are already provided, and some of them would fill that set of candidate sites, which we'd be evaluating later. To determine where patients are located is a bit more tricky. The most granular data you could get would be an individual patient living in a location, traveling to a trust, but that data obviously is not available. So the next most granular data that we could use is using these lower super output areas, which are very small geographic regions in England, where you kind of divide the map of England into these some 30,000 of these regions. And within one of these regions, we see around 1,000 to 3,000 people. And because it's such a small region, we can kind of assume that the distance from the center of that region to where a treatment site is located is a somewhat reasonable estimate for the travel time that a particular patient living in that region would have to travel. So what we do is, given these LSOAs, if there's prevalence data available for a disease by LSOA, we would use that, but in a lot of cases that isn't. So what we do is we take the disease demographics, so for MS in this case, looking at the breakdown of the prevalence rates by age and sex, and then look at the Office of National Statistics data for each lower super output area, which gives us a breakdown of the demographics in each one of those lower super output areas to give us sort of a expected value for the prevalence within each LSOA. So that tells us where the current sites are and where the patients are. The next step is to figure out where patients are going, how long it takes them to get there, and what the impact of that is on outcomes. So to determine where patients were going, we made a simplifying assumption, which was that patients would travel to the treatment sites that were closest to them by car. And then to figure out what treatment sites would actually be closest to every LSOA, we looked at pairwise travel times between the center of each LSOA and these service sites. There's a ton of these pairwise travel times, so it wasn't feasible to run locally. So we ran this virtually on a AWS virtual machine, and we used OpenStreetMap and open source routing machine to get this travel time data. Once we had this data, we could determine for a given lower super output area what the actual closest treatment site was in terms of travel time. And then the next step is to assume some relationship between travel time and treatment selection, or travel time and adherence. And once you've done that, you can start connecting things to outcomes, because you know, for example, maybe how likely someone is to attend a treatment administration appointment in a year, and you can connect that to things like their out-of-pocket costs for travel, or things like the environmental impact of that travel. So that gives us a sense for what the outcomes are across England given current access to treatment sites. The next step is to take a set of candidate sites and figure out which ones are the best in terms of how they would improve a particular outcome. So the way that we do this is with this greedy search process. So if I think of an outcome like adherence, we'd start out by looking at what adherence currently is in England for patients, and assume we want to maximize it. What we would do is introduce one candidate site, see what patients would now be closer to that candidate site and therefore switch, and then calculate what the overall impact would be on adherence across patients in England. Then you repeat that process over and over again, including one candidate site at a time. And at the end of this, you take the candidate site that improved adherence the most, add it to your ranked list, and repeat again. The key thing here is that you don't include the candidate site that you've already put in the ranked list. Sorry, that you do include the candidate site that you already put in the ranked list among the set of existing sites so that you don't get clustering all within a small region. Okay. This process is something that we initially implemented in R and was quite slow the way that we did it. So to make it go faster so that we could run the greedy searches live in the app, so that's where someone's picking an outcome of interest like adherence, but in our case, something like minimizing travel time. To make sure that this would run quickly enough in the app, we implemented it via RCPP in C++. And I'll show you a brief demo, just showing some of the different functionality within the application. And that's a video here, so give me a second. Just need to switch over to that. So this is the map with the treatment sites all displayed. In red, we have existing treatment sites, and in blue, we have candidate treatment sites. We can also display on the map the individual LSOAs. And we can also have a look and see for those LSOAs how far they have to travel to get to treatment. If we look back at the LSOAs, which are those drawn regions, we can also see the particular outcomes that we expect people to have when traveling from a particular LSOA. So for patients within this LSOA over here, we can have a look. The histogram here shows the distribution of travel times from all LSOAs in England to their nearest treatment site. And the dotted line in red shows the travel time for this particular LSOA. To set up a greedy search, we run through the sidebar here on the left. For this particular search, we'll look at sites across all of England. So the next thing you select is what you want the greedy search to minimize. And in this case, we have the options of minimizing travel distance or minimizing travel time. Then you pick how many candidate sites you're interested in ranking. So we'll start with 10, and you just hit run search, and it runs in the background and displays on the map where the best positioned sites are. To see the impact of adding ranked candidate sites on particular LSOAs, we select an LSOA. So for example, if I select an LSOA that's closer to this candidate site here, where previously they would have had to travel up to Colchester or down towards central London. You can see here on the histogram where the red histogram previously was the distribution of travel times before the ranked sites were introduced. The blue histogram represents the distribution of travel times across LSOAs when the ranked sites are introduced, and the difference between the red vertical line and the blue vertical line is the travel reduction that a particular patient traveling from this LSOA would experience. So it helps us to see what the impact can be on a very local level for patients. We can also look to see what the impact of these ranked sites would be on outcomes across England. So by selecting ranked sites from this table, the impact on patient outcomes across England are displayed here on the left, and we can select individual sites or a combination of sites to see their aggregate impact. Finally, you can see the impact of making all of the ranked sites available, so all 10 of them in this case, on patient outcomes across England. Oh. Okay, so that's the demo. There's a longer demo and more details about the methods on a talk we've done previously on YouTube. That'll be in the slides later if anyone's interested. So looking ahead, I want to talk a bit about some of the technical limitations of what we've done. So right off the bat, the approach is best suited when you have a discrete number of existing and potential sites. So it's not designed for looking at, for example, the best location for a mobile care site. The next thing is that there's really a need for better data sources. So that kind of relationship that I talked about between travel time and adherence and travel time and treatment selection is really critical to kind of trusting the outcomes of this framework. And that should be informed by some separate study or something that we find in the literature. There's also a need to improve the estimates of prevalence by LSOA, I think beyond just a simple expected value calculation based off of the demographics within each LSOA. And the final point is that, not everyone is traveling by car, especially in cities. People will be using public transport, and what the closest site is by car with no traffic is going to be very different from what the closest site is, in London on the tube. Okay, I'm going to hand over to Lewis to talk about some of the bigger picture implications of the work.
Thank you. So in terms of kind of the value cases, I think this, what I've put here kind of provides insights to healthcare decision makers, and I think that's what they are. They're insights. It's not kind of a true reflection, and the numbers aren't exact in these kind of models, based on the data that we have available, and also you're speaking to healthcare decision makers and telling them that services are or patients are underserved in the east of England and in the southwest, and everyone kind of knows that's the case. It's good that it puts it in a map and it shows the potential options and the potential areas that we could improve access. And clinicians and payers in those areas are trying the best to facilitate uptake and service development there. But this is a different way of showing them the issue that they obviously already know about. Oliver mentioned before around this works on kind of a finite number of candidate sites, and that's true, but it pinpoints an area that could benefit from some service development. That doesn't have to be at the local hospital. It could be a mobile site, but it happens to be in that city or in that town where it is. So it doesn't have to be explicitly in those areas because of the kind of subcut formulation that we have and where it can be delivered. And I think the value in this is maybe moving it towards this kind of broader value of medicine, the value of convenience, the value of this decentralized care and care close to home, not necessarily just on the national kind of value case that we use in NICE submissions, but bringing that societal perspective, bringing in the productivity, the societal benefits that we have on kind of convenience of access. The challenges, I think you are all very clever in this room and you will understand a lot of what Oliver mentioned here, but the difficulty that we've had in terms of rolling some of this out is understanding what geospatial modelling is within health economics, and then within an NHS infrastructure that deal with these conversations and pay a conversation on a daily basis, but haven't seen things like this before. So it is upskilling, as a lot of the R modelling is, but with a new demographic of people, not just health economists, but kind of field teams and market access people and people that aren't used to the same kind of level of modelling that we do. And then we need to get some learnings from this pilot model because it has been used internally, but in terms of rolling out and speaking to some of these commissioners, we get kind of trickle through requests, but it hasn't been rolled out nationally yet, and we haven't done some of these service developments yet. It's all still in pilot phase. It's all still hypothetical. So yeah, we kind of waiting to see more, I suppose. And then there's kind of an open question here around kind of best disease areas for future work. We had some examples on the previous slide. We rolled with MS, as I mentioned, but in theory, I'm confident this could work in kind of any hospital-administered treatment, anything where travelling to the hospital is a burden on patients. So we in Roche work across a wide range of disease areas, one of them ophthalmology, and I think that a patient with eye problems getting to hospital is obviously an issue. So if we can bring them closer to them, then maybe it works a little bit better there. The same for a lot of kind of chronic conditions where you have a lot of appointments. And there's a very bold call out, I suppose, here at the bottom that Ollie's put in around that you can't see, I suppose, but we've submitted this work for an issue panel at ISPO Europe in Vienna. Is it Vienna? Yeah. So we'll see what people think about it and if we actually do it there. But maybe this was somewhat of a trial run if it gets accepted. All right.
Time for one question in the room.
Oh, it is.
Yeah.
I wanted to go back and ask you about your assumption that everybody's travelling to the hospitals by car. And I know you said it's an assumption. And I'm just wondering if you considered the inequality impacts of that assumption, because in areas that have lower socioeconomic status, that assumption might be bigger than in other areas, and then the consideration of the different levels of public transport provision, for example, comparing cities to rural areas. And I think, in higher income rural areas, the assumption that everyone's travelling by a car is probably quite an accurate one, but in other areas it wouldn't be. And I think particularly in lots of patients that are travelling to hospitals quite a lot, you would probably find that there's quite a socioeconomic gradient of people that don't have cars. And I understand there's probably all due to data limitations, but I'm just wondering if you've considered how you could model the potential inequality impacts of that assumption. I appreciate this isn't really an R question, but yeah.
I don't think it's something we've considered deeply at this stage. I think the focus was to sort of get a framework and something working right off the bat. So doing things with travel time via car was like the most straightforward way to do it. But I think going forward, yeah, it would definitely be something that we would need to consider. Does anyone add to that?
I think you're right that there's so much potential with this work. It's just we started with the framework and we had to make some assumptions, but hopefully we can fill in the gaps. And there is some deprivation statistics in there, but it's very much kind of index of multiple deprivation. We haven't looked at the kind of correlation between that and then with transport and other things. But if the data's there, obviously there's so much that you could do with it.
Okay.
Hi. You got an absolute ton of online ones. Do you want to pick your phone?
Oh. So yeah, there are a lot of them. I guess I can ask one, just did you consider capacity constraints like waiting lists, and were these important for the model?
I suppose kind of the same answer really. It's how we could do so much with it. We haven't in this, but initially one of the big picture ideas is there was a bit at the start where we looked at waiting lists in certain trusts, and therefore the potential to target those trusts and one of the value messages of it is that we could reduce neurology waiting list time, for example, within MS. But the data that goes into that we haven't pulled, and it's not in the model. But as Ollie said, it's a framework to get us started, and there might be different kind of branches that we go off and tell different stories with this kind of tool. So yes, but no, if that answers the question.
Cool. Right. When you get back to your seat, you have quite a lot of questions.
Okay, thanks very much.